którego będzie nawiązywał. To pojęcie, które się będzie pojawiało u Tala, czyli bedwetting, w odpowiednim języku polskim moczenie nocne. Znaczy będzie to przede wszystkim zjawiska moczenia się, enurezy, zwłaszcza moczenia się nocnego.
Możesz też powiedzieć dlatego, że Tal jest gwiazdą naszej konferencji, because Tal is the star of our conference. He has no limited time.
Ja sobie tam się to może.
Możesz zacząć.
Czy Tomek już wrócił?
Tak, właśnie tak zamknął.
Ale idź usiąść.
Nie, idź usiąść.
Poradził sobie.
Tak.
Dobrze.
Nie będę jeżeli zajrzeć do niego.
So Klaus has already presented me, so I'm Tal Sagie. I don't need to say anything more than that. Thank you. And I'm a PhD student, as you understand, here in Amsterdam University. I said I'm going to say supervised by Professor Discourses and Mateusz Marcini. Today I'm going to speak about behavioral cyber treatment in general, but more specific about our cyber treatment for bedwetting, which will demonstrate in general the whole idea. If I'm speaking too fast, just stop me. It won't make me maximum 2 hours of finishing. So it's called TheraPee. You see here by Dr. Sagi. Don't say I'm trying to be. I'm not a doctor yet. Dr. Sagi is my father. 30 years ago, he started his business, bedwetting solutions all around the world, and I joined about 15 years ago. So let's get started. I'm going to discuss in general, very shortly, what is Enuresis, bedwetting, a little bit about the relationship between social and emotional functioning to Enuresis, behavioral treatment for Enuresis, our multi-modality program, cyber treatment in general, and therapy. So, what is bedwetting or nocturnal Enuresis? This is an involuntary micturition during sleep after the age of 5. We usually expect a child to stop wetting the bed between the ages of 2 to 4. At the age of 5, still there are a lot of bedwetters out there. The DSM-4 defines it as an emptying of urine into clothing occurring at least twice a week for at least 3 consecutive months in children over the age of 5. There are a few reasons for bedwetting, but it's very important here to say that bedwetting is usually not a medical problem. It's not a medical, it's not a psychological problem. Most bedwetters are normal children or normal adults. They have just one problem. They cannot control the bladder while they are asleep. So while they are asleep, the same signal that comes from the bladder to the brain does not get the right interpretation. And therefore, the child, instead of contracting the muscle in the bladder, he just releases it. There's one thing that we can say for sure about bedwetting. They are defined as very deep sleepers, something that characterizes them most. Most parents will describe subjectively the child as impossible to wake them up. There are very, very deep sleepers. Continue?
Yeah.
Okay. For example, a child that is a bedwetter in very deep sleep, he can find some very awkward situation like the following one. And it looks, a little bit awkward, but this is something that can happen. He can wake up during the night, start to walk through the room, and find himself on the stairs like that. We had very awkward cases that we heard about a child that, with his eyes closed or opened, we went through the stairs, got to the living room. There was a nice carpet there, but not anymore. Or in another case, he opened the refrigerator, and it happens there. He thought he was in the bathroom, but he's not. We also know that bedwetting is genetic. Enuresis runs in families with a reported risk of 77% where both parents themselves were enuretic. Okay, so if you know somebody that was a bedwetter, suppose his mother is the one to blame, or his father, an uncle, somebody in the family had a bedwetting issue in the past. Bedwetting is considered to be one of the most frequent disorders among children. It's the second most prevalent phenomenon among children worldwide. The first one, by the way, is asthma. 25% of children still wet the bed at the age of 4. 5 to 7 million children in the US are suffering from bedwetting. By the way, at the age of 18, plus 1 to 2% of the population still wet their bed. We know that there is a great influence, a great effect of being a bedwetter on the functioning of social and emotional functioning. There are some researchers that we know they reported about significant increase in psychological difficulties, in some cases. We also know that there is an increased risk for psychiatric symptoms, so we understand that this is a very common problem and it has an effect on the self-esteem and self-confidence of the child, so we need to do something about it. So what can we do about it? So here comes the interesting part. There are a lot of current solutions. We don't have enough time to discuss all of them, so right now I'm going to discuss the most effective one and the most common one. I forgot here something, 1 second. So one of the most effective treatments for bedwetting is the behavioral treatment for bedwetting using a bedwetting alarm. Now there are a lot of bedwetting alarms. I'll show you one of them right now. The idea about the bedwetting alarm that we have a sensor pad and we have an alarm that is you put next to the child's bed. Okay. Very simple. It's not an iPhone, but and this is considered to be the most fancy, the fancier in the market. So the idea is very simple. You have a sensor pad, okay, you can see it here, okay. You put it underneath the sheet, okay, underneath the linen. As soon as the first drop of urine touches the pad, the alarm rings, and it's, okay. Now what basically happens, everybody wakes up, but the bedwetter continues to sleep like nothing happened. That's what usually happens. So what's the idea about the Enuresis alarm? The idea is to make a connection between the bedwetting, the buzzer, and the unpleasant experience of waking up and going to the bathroom. When we repeat this procedure again and again, the brain makes a connection between the whole process here, and we start to gradually see that the size of the urine spot is getting smaller, the time of the bedwetting is pushed towards the morning, and eventually the child gets dry nights. So you need to repeat it again and again and again. Here is that. So the idea is to alert the child to respond fast. Enuresis alarm is about 70% effective. So 70% sounds high, but it's not too high. This is why we came up with our multimodality program, which involves not just this bedwetting alarm, but also cognitive behavioral therapy and also various therapeutic techniques. When we combine them all, we get more than 90% success rate in such a program. So this is considered to be the traditional program, but the idea is how to take this traditional program and transfer it, replicate it to a cyber program, which is supposed to be not so different. So just a little bit about cyber therapy. We know that face-to-face therapy was rated higher by patients. That's what a lot of researchers say. But we also know that there are some studies that found that there's no significant difference between providing a face-to-face therapy compared to an online therapy. So here comes the idea of the cyber program. Now, I'm not referring to cyber program as a program by Skype. Okay, cyber program can be starting from emails one to another, like an asynchronous situation, but it can also be a treatment by Skype. But Skype is not so different than traditional program. I mean, okay, you're not sitting in the same room, right? But it is, the challenge was a little bit different. The challenge was to try and create an illusionary therapist-assisted systems, a computer that mimic the interaction between the therapist and the client. I want him to work for me. I don't want to do the job anymore, okay? So he's going to do all the hard job with the patients. And here comes the idea about therapy. So what do we try to do? We try to resemble the current face-to-face treatment. We try to use special algorithms that is the mind of the whole system. And we use two different platforms. The first one is a virtual child. The second one is a virtual therapist. By using these, we manage to replicate the same thing that happens inside the clinic, in our inpatient clinic, to what's going to happen in the child's home, the child's natural environment. So what we basically do, the child gets a personal activation code, he logs in the software, and inside he provides with his parents all the data about his situation, and then he will get the first chart. This is Mateo's chart, okay?
Thank you.
So, when the child comes to the clinic and meets me in person, I'm going to give him basically the same chart, you know? I'm going to give him this chart. It doesn't look so fancy. The virtual chart looks better. So he gets these stickers and the chart. So this is exactly the same, but in this generation, children tend to be more engaging when you put something digital. It can run on iPads and so on, so it's much more interesting than this paper here. We ask the child to start and use the stickers. If he's dry, he's going to get a blue sticker. If he gets a few nights in a row, 4 nights in a row, he's going to get a big red sticker. So we're using reinforcements, short mid reinforcements, and midterm reinforcements. And the parents are going to report about the incidents. They're going to provide the time of the bedwetting, the size of the viewing spot, the waking response, if the child woke up or not. And using this data will help us to continue the program. So when the patient comes to me in the traditional program, I'm going to talk to him as we talk in any private clinic, right? But what happens here? I'm going to talk with him.
Hi again. I'm very pleased to meet you and to have the opportunity to help you stop wetting the bed.
So he's sitting in his room with his parents, and this is what's on the screen. But this is not enough, because it's not like a regular step-by-step program. It has to be a little bit more, right? It has to be tailor-made so he can feel that this is something that is more personal. This is why we use a lot of video clips, like hundreds of video clips. And these basically take the whole program, which is a tailor-made program, cut it into slices. And we use these video clips depending on what we see in the virtual chart, okay? So we know to choose the right clip in order to make it a tailor-made program. So for example, let's take a look at this chart here. You can see this chart, this few first nights here, the child